Hello everybody. Today we are going to discuss about acute pancreatitis recent update. So acute pancreatitis is the common gastrointestinal disease worldwide, often requiring hospital admission. Over the past decade, the global incidence has increased with an average annual rise of 3%. Common risk factors are alcohol use, obesity, advanced age, gallstone disease, contributing to this increasing incidence. On imaging, acute pancreatitis can be classified as acute interstitial pancreatitis or necrotizing pancreatitis, each with distinct morphological features and the treatment strategy. While abdominal ultrasound at admission is essential to identify gallstone or sludge, early computed tomography should only be performed in case of diagnostic uncertainty. CT scan can be considered if there is no clinical improvement after 3 to 5 days. Now about prediction of severity. About 20 to 30% of patients develop moderately severe to severe pancreatitis with considerable morbidity. Mortality up to 30% in case of infected pancreatic necrosis. Early prediction of disease severity is desired to identify individuals who may require more intensive management for counseling and for stratification in clinical studies. Current predictive tools such as individual biomarkers, for example, CRP and scoring system, for example, SIRS and the Glasgow Emery criteria do not accurately correspond with the observed clear disease severity. So there is an overview of disease classification and local complication according to revised Atlanta classification. So the disease is mild if there is no organ failure and the local and systemic complication. If it is classified as moderately severe if it is transient organ failure of less than 24 hours or local or systemic complication. It is severe if it is persistent organ failure and the local or systemic complication. Then acute interstitial pancreatitis, acute peripancreatic fluid collection. Interstitial edematous pancreatitis with homogeneous non-encapsulated peripancreatic fluid collection in first 4 weeks. Pseudocyst interstitial edematous pancreatitis with encapsulated acute fluid collection persisting beyond 4 weeks. Acute necrotizing pancreatitis, diffuse or focal areas of non-viable pancreatic tissue in first 4 weeks. Then walled-off necrosis, encapsulated heterogeneous non-liquefied collection of pancreatic necrosis with well-defined wall, usually more than 4 weeks after onset. Now about treatment, key aspect of management of acute pancreatitis, early phase of medical intervention, which includes fluid resuscitation, nutrition, pain management, antibiotic therapy, and invasive pancreatic intervention and long-term sequelae. About early phase of medical intervention. Currently, no drugs or measures are available to intervene in the natural history of acute pancreatitis by modulating initial inflammatory cascade. So the early management is based on the combination of monitoring, supportive care, pain medication, and management of complications in multidisciplinary fashion. Prophylactic antibiotics reduces overall infection but do not prevent pancreatic infection, pneumonia, urinary tract infection, complication, interventions, or mortality. Selective decontamination of digestive tract can be considered in critically ill patients in setting with low prevalence of antibiotic resistance. About fluid resuscitation, acute phase of acute pancreatitis is characterized by the local hyperinflammation and vascular endothelium damage. In case of moderately severe to severe pancreatitis, excessive systemic inflammation and vascular permeability lead to the fluid accumulation to the third space, reduce organ perfusion, and consequently pancreatic microcirculation. So early fluid resuscitation is simple yet crucial supportive therapy to maintain adequate organ and pancreatic perfusion and thereby reduces the risk of organ failure and shock. Retrospective studies have demonstrated improved clinical outcome of early fluid resuscitation, but extend to the late admission as well. If that means if the patient's admission is late, that is more than 24 hours, then also the fluid resuscitation strategy is beneficial. So the relationship between infusion rate of the fluid and the development of the complication has been under debate, especially concerning the infusion rate that maximize the benefit before causing iatrogenic fluid overload. So guidelines, if you see the previous guidelines, they were all supportive of aggressive early hydration. But recently, the waterfall trial published in NEJM, which randomized 249 patients, and they have categorized this patient into the two category, that is aggressive fluid resuscitation and the moderate fluid resuscitation. Aggressive fluid resuscitation include bolus of 20 ml per kg followed by infusion of 3 ml per kg per hour. And the moderate fluid resuscitation include bolus of 10 ml per kg followed by 1.5 ml per kg per hour of fluid resuscitation. And what they found is there was no significant difference in the mortality between aggressive and the moderately aggressive resuscitation. But aggressive fluid resuscitation was associated with increased fluid overload, and aggressive fluid resuscitation is associated with significant higher rate of organ failure, pulmonary and the renal complication. Therefore, moderate fluid resuscitation with an individualized goal-directed approach is now standard care. So strategy should be tailored to the individual risk profile and individual risk resuscitation goal using combination of clinical sign, physical examination, vital sign, urine output, biochemical marker, and imaging results, and the advanced invasive target in case of intensive care unit admission. Now about choice of fluid. Ringer's lactate contain electrolyte composition more similar to the plasma. In theory, colloid fluid could effectively expand the intravascular compartment by oncotic pressure and restore albumin level affected by hyperinflation and the nutritional status. However, no benefit of colloid could be demonstrated in acute pancreatitis in sepsis patient in ICU setting. Therefore, moderate fluid resuscitation with balanced crystalloid remains the standard approach, that is Ringer lactate. In 2026, we are expecting the Waterland trial to provide final evidence on which type of the fluid should be ideally used. Now about nutritional support. Historically, patients were advised a period of fasting to allow pancreas to rest and the inflammation to subside. However, basic research has shown that adenosine triphosphate, that is ATP, is crucial for restoring mitochondrial damage and the cell function in the early phase of acute pancreatitis. Additionally, clinical trials have demonstrated that early oral feeding support recovery and leads to shorter hospital stay in patients with predicted mild and moderate pancreatitis. So very early, that is less than 24-hour, was not superior to early, that is more than 72-hour on-demand enteral feeding in severe pancreatitis. Furthermore, tube feeding was not required in 69% of the on-demand group. Therefore, tube feeding can be commenced after 72 hours if on-demand feeding is insufficient. Based on the limited evidence, nasogastric feeding is non-inferior to nasojejunal feeding unless gastric outlet obstruction or severe vomiting is present. When both oral and enteral tube feeding is not feasible, parenteral nutrition should be considered, but this is rarely necessary. Now about pain management. Abdominal pain is most common and the burdensome symptom of acute pancreatitis. Its intensity may be linked with the disease severity. Neither NSAID nor opioid have shown significant impact on preventing the progression of acute pancreatitis after onset in the human. In randomized trial, opioid had a similar pain control, adverse event, and clinical outcome compared with other analgesics. Pain management includes starting with non-opioid analgesics such as acetaminophen and NSAID, adding weak opioids such as second stage, and if necessary, titrating to the strong opioid. For severe acute pancreatitis, both step-up and step-down approach have been suggested. Smaller studies have shown the safety and feasibility of epidural analgesia in acute pancreatitis and hypothesized the benefit of epidural analgesia on clinical outcome by improving splanchnic perfusion. However, this could not be demonstrated in multicenter study of acute pancreatitis in ICU. So if the for the management of the pain in pancreatitis, the current practice statement is to start with the NSAID, and if it is not, and if the pain is not controlled, then switch to the opioid. Now about antibiotic therapy. Following hyperinflammatory phase, the excessive anti-inflammatory response can cause relative immunosuppression, increasing the risk of pancreatic and extrapancreatic infection. Nevertheless, sterile SIRS is also common during early phase of acute pancreatitis and can be classified as infection. However, in our daily practice, the antibiotics are initiated in 31% to 82% of patients with acute pancreatitis, often early during admission, that is, within less than 7 days without clear source of infection. So, appropriate diagnostic for pancreatic infection should be performed based on localizing symptom prior to the initiation of antibiotic. Recently, a single standard randomized trial found that use of PCT, that is the biomarker specific to infection rather than inflammation, to guide antibiotic decision, reduce the antibiotic use compared to standard care without affecting clinical outcome. Infected necrosis, mainly more than 80%, occurs after 14 days and can be identified by persistent clinical deterioration in the absence of other infection, gas configuration in the peripancreatic collection, and positive culture from pancreatic tissue. So, for infected necrosis, antibiotics are the first step of treatment alongside supportive care. Generally, empirical broad-spectrum intravenous antibiotics that cover gram-negative and gram-positive microorganisms are recommended for minimum of 1 to 2 weeks. However, evidence regarding choice, timing, and duration of antimicrobial is lacking. Blood culture and the cultures of necrotic tissue during pancreatic intervention are essential to facilitate targeted antibiotic therapy in consultation with microbiologists. Additionally, fine needle aspiration can be considered in case of diagnostic uncertainty or to apply targeted therapy. An upcoming randomized trial of the Dutch pancreatitis study group will investigate whether an optimized and standardized antimicrobial treatment based on antimicrobial stewardship principle can improve clinical outcome. Finally, the long-term broad-spectrum antibiotics increase the risk of fungal infection, but no randomized study on antifungal prophylaxis in infected necrosis are available. So, regarding invasive pancreatic intervention, in acute biliary pancreatitis, endoscopic retrograde cholangiopancreatography is only indicated in case of cholangitis and can be considered in case of biliary obstruction. Sterile pancreatic fluid collection are often self-limited and rarely require invasive intervention. Only in case of persistent symptom, preferably at least 6 weeks after onset, drainage can be considered, keeping in mind the risk of secondary infection of necrosis and associated need for additional necrosectomy procedure. Drainage of the infected pancreatic necrosis is indicated when antibiotic therapy fails to achieve source control. The Pointer trial, 39% of patients with infected pancreatic necrosis did not require any intervention to achieve clinical success, and postponed drainage, that is more than 4 weeks, resulted in fewer intervention and similar clinical outcome compared with early drainage. Ideally, intervention is delayed until infected necrotic collection is more mature and demarcated or completely walled. For critically ill patients with persistent organ failure, there is also no evidence to support early drainage. Their treatment should be personalized and managed by multidisciplinary team at specialized center. Patients with parenchymal necrosis as compared to extrapancreatic necrosis are prone to complications that require intervention. Now, the next complication is disconnected pancreatic duct. It is a frequent complication of parenchymal, especially central gland necrosis, and associated with worse clinical outcome, higher rate of pancreatic intervention and complication and recurrence. So the prophylactic pancreatic duct stenting is not recommended to prevent disconnected pancreatic duct. MRCP, that is magnetic resonance cholangiopancreatography, is recommended as first diagnostic modality. Indication for intervention is based on symptom related to consequences of disconnected pancreatic duct. In case of symptomatic pancreatic fluid collection, long-term internal drainage with double pigtail stent is preferred. For other indications such as pancreatic intracutaneous fistula or pancreatic ascites, pleural fluid, endoscopic retrograde pancreatography can be considered with, if possible, leak bridging stent. Consider other options such as surgical drainage procedure or in case of disconnected pancreatic duct located in the tail of pancreas, distal pancreatectomy. Over time, drainage strategies have shifted significantly. First, the minimal invasive surgical step-up approach showed superiority over open necrosectomy in terms of major complication and mortality. So two-step approach were compared. The surgical approach with percutaneous catheter drainage and surgical necrosectomy if needed, and endoscopy approach that is transluminal drainage and endoscopic necrosectomy if needed. So endoscopic two-step approach demonstrated better short-term as well as long-term outcome in major complication, organ failure, and especially pancreatic fistula development. Endoscopic step-up approach is now first choice strategy. Collection that are difficult to access from the upper GI tract, such as collection deep in the pelvis, paracolic gutter, still need percutaneous drainage. Multiple drainage may be necessary for extensive and multiple unconnected collection. For endoscopic drainage, either lumen opposing metal stent or double pigtail plastic stent are used. It was hypothesized that metal stents are larger diameter and would enhance drainage and facilitate subsequent necrosectomy. However, no benefit of lumen opposing metal stent over plastic stent could be demonstrated. It can be argued that plastic stents are cheaper and more patient friendly and provide opportunity for long-term internal drainage for patients who develop disconnected pancreatic duct. The placement of lamps is easier and can be performed with fluoroscope. When using lamp, that is metal stain, the addition of plastic stain through lamp reduces the risk of adverse event and stent occlusion. When insufficient clinical improvement is achieved after initial drainage, the endoscopic necrosectomy and video-assisted retroperitoneal debridement is indicated. Multiple endoscopic necrosectomy procedures are often required for clinical success. Direct endoscopic necrosectomy during initial procedure rather than subsequent intervention following drainage was recently investigated in randomized trial in stabilized patients with walled-off collection treated with the lamps. Direct necrosectomy reduces the number of interventions needed to achieve clinical success. Future clinical trials are needed to evaluate new technology and device to perform endoscopic necrosectomy more efficiently, such as powered endoscopic debridement. Splanchnic vein thrombosis is frequent and early complication of acute necrotizing pancreatitis. While pancreatologists generally support the use of therapeutic anticoagulation such as low molecular weight heparin for 3 to 6 months, clinical benefit relative to the risk of bleeding remain uncertain. High quality prospective trials are necessary to explore the impact of anticoagulant on clinical outcome as well as to determine optimal timing and duration of therapy if indicated. About follow-up and long-term sequelae. To prevent recurrence and biliary complication after acute biliary pancreatitis, cholecystectomy is preferred during the same admission for mild case and generally within 8 weeks for necrotizing pancreatitis. In mild acute pancreatitis, discharge usually takes place within 1 week. However, multiple prospective studies indicate that early discharge within 24 to 48 hours with enhanced outpatient services or remote monitoring may be feasible and safe in this patient. Long-term complication can develop within years post-admission. Endocrine and exocrine insufficiency represent most frequent long-term sequelae of acute pancreatitis. This underlines the necessity of annual checking for exocrine and endocrine insufficiency in the years following acute, especially necrotizing pancreatitis. Early appropriate management can reduce their burden and improve quality of life. Additionally, the development of recurrent acute pancreatitis and chronic pancreatitis are common, especially for alcoholic etiology. So adjusting lifestyle could be one of the most effective intervention to improve long-term outcome, and clinicians should ensure patient recognize the potential benefit of the preventive health measures. Thank you guys.